Hello, this is Dr. Bhavik, and welcome to my pediatric endocrine lecture series in my YouTube channel. And today I'm going to discuss something which I consider is very interesting and informative, and also shows what the medical progress has been made in this area of this disease condition. So, what I'm going to talk to you about the late effect of cancer therapy in children on endocrine functions. And this topic should be pretty interesting to not only a pediatrician but to pediatric endocrinologist, pediatric endocrine fellows, as well as hematologist, oncologist, and the fellows of the hematology and oncology section, as well as the nurse practitioner who does take care of oncology patient. And without further ado, let me allow me to say that this condition is one of the very fascinating one, because so much progress has been made over the period of decades. One need to remember that cancer in pediatrics less than 18 years of age is the number one cause of medical death. I say medical death, although we know the violence, gun violence, accident, all number one. But when you consider the medical death, that is number one. But we have come a long way. And the 5-year survival rate has increased tremendously, in approaching about 90% in many of the childhood cancer. And so I will be discussing them, and in order to make a justice for these topics, I have decided to divide it in two parts, part 1 and part 2. In part 1, I will be discussing about the most common one, like a growth hormone deficiency, and the second part will be discussing about other endocrine malfunction that has been regularly associated after cancer therapy. So let's start with the next slide. And those who are coming to this lecture now, allow me to introduce myself. I have been and I was on the academic medicine for many years, and always been in medical center, 20 years in a military medical center, where I was intimately involved with the care of the endocrine part of the care of children with childhood cancer, as well as University of South Alabama College of Medicine, and helping working with the hematologist, oncologist related to the endocrine problem in cancer therapy. And I have decided to make the slide a little bit more elaborative, so that when you are reading the slide, you will get almost all information. And so it is almost like a handout. Although that may not be the best way to approach, but that's what I'm going to do. So overall survival rate approaches to about 85 to 90% for certain conditions like acute lymphoblastic leukemia, non-Hodgkin lymphomas, about 84%, neuroblastoma and osteosarcoma, about 65 to 70%. These are the recent data I have got it, so it is not, this data is 2018, update up to 2018. And how that has happened? This has happened because of multi-modality of therapy like surgery, chemotherapy, radiation therapy, whichever is necessary for this patient. And as a result of that, unfortunately, although we have achieved a tremendous amount of success in that area, however, we have also have to pay a price in certain area, and especially I'm an endocrinologist, I will be talking about endocrine dysfunction. When you talk about the endocrine dysfunction, first thing should come in your mind is short stature. So most of the concern of the children, those are treated for cancer, especially leukemia, neuroblastoma, and the cancer will be on for short stature, and the short stature can be endocrine as well as non-endocrine. If you are talking about the endocrine cause, the most common one will come to your mind is the growth hormone deficiency, mainly. But there are other things involved that I will be discussing when I talk to the other endocrine cause elaborately. So non-endocrine cause also give the growth retardation, especially if there is a radiation in a spinal area. Spinal area and children with malignancy also associated with malnutrition. Sometimes tumor might recur, and as a result of that, the growth of children may be interfered. So endocrine cause, as I told you before, is the growth hormone deficiency. Then at the same time, there are some of the children, in addition to the growth hormone deficiency, they might develop premature sexual development or precocious puberty and hypothyroidism. Just mind you that growth hormone deficiency will give growth retardation, premature sexual development, advanced the bone age, and end result will be also short stature, and we will know this very well. And hypothyroidism is one of the most common cause of short stature in children, especially in girls. So let's talk about the growth hormone deficiency. And this result primarily when there is radiation to the hypothalamic pituitary unit. And deficiency of growth hormone is related to the dose, the radiation dose, and this is a publication. I took it from Memorial Sloan Kettering Unit, Cancer Hospital in New York, and it says that it has, if you have radiation dose is 1800 centigrade, this is rad. The incident increase over the period of time after 2 years after the therapy. Usually you see the declining in growth velocity. However, if somebody has received 300 centigrade, almost 100% are going to be growth hormone deficient. And if they have received somewhere between less than 300 to 2000, the 50 to 60% of the children will develop growth hormone over the period of 2 to 5 years. Now, I can show you that this is about the higher the dose, this is the higher dose stomach. You can see that the incidence of the growth hormone deficiency is almost like dropping. So first within 3 years, they are growth hormone deficient, and if they are in between somewhere, then again the deficiency period could be up to 4 or 5 years, yeah, after radiation. Again, this slide I have taken from Memorial Sloan Cancer Institute in New York. So growth hormone deficiency, not only the deficiency of the growth hormone, but there is a condition, it usually happens when the dose is not that high, called neurosecretory dysfunction of growth hormone secretion. And this usually occurs with a lower dose. And if somebody is doing the growth hormone stimulation test, then test will be normal by using the criteria the pediatrician and pediatric endocrinologist use to make the diagnosis of growth hormone deficiency. So the site of the injury could be at the level of hypothalamus. However, hypothalamic pituitary area also may be damaged, but not only hypothalamus pituitary area. Now, one need to understand a little bit about what is neurosecretory dysfunction. As we all know, the growth hormone secretion occurs in a pike and volley, and the most of the growth hormone secretion occurs at night with slow wave sleep, non-REM sleep, and there seems to be about at least 8 pulsations throughout the night. Again, the pulsation and the peak of the pulsation is important. So many a times, if that is not happening, one would not see the growth. So these children will respond to the growth hormone, but growth hormone stimulation test will be quite unrevealing. Now, spinal irradiation is clearly a very disappointment in terms of growth in children, and the pediatric endocrinologist, if that's what is causing the retardation of the growth, then it is bad news, because growth hormone is not going to help to increase the length of vertebrae, or impact will not be altered by growth hormone therapy. Again, this depending upon the dose of the radiation and also age. Treated less than 6 years of age with the dose of above 25,000 rads, growth failure will be first 2 years following the cerebrospinal, craniospinal radiation of the brain tumor, and it is due primarily to the impaired growth of spinal spinal column or vertebrae. And the premature sexual development is interesting in the sense that the result of childhood cancer therapy could give either delayed puberty or early puberty. And if it is early puberty, this is clearly has damaged the hypothalamus pituitary axis, and therefore the mechanism that has been set for the onset of puberty is not controlled, and so it might occur as a result of disruption of this physiological pathway. And it is seen in children if the dose is 15 to 2000 rats and above 300 or 3000 rats for brain tumor. And if you go through the data and look, then you will see that it is associated with more of a female sex and younger age. So in the younger age, if they have received the said amount of radiation for brain tumor, they're most likely going to develop precocious puberty or premature sexual development. And as a result of that, the final height will be jeopardized, and if the growth hormone deficiency is there as well, so that will be double whammy. What about the effect of chemotherapy on growth? There are many mechanisms that I have read. The many articles has got different views, but my purpose is to give the what is really everybody accepted. Now, this chemotherapy related growth is also depending upon what kind of chemotherapy has been used. And alkylating agent, actinomyces D, and that has been cited as probably more common cause of chemotherapeutic agent that has caused the growth retardation. And as a result of that, there is a growth failure, and it is also believed that sometimes it also does changes the growth potential at the level of the cartilage. So therefore, there may be multifaceted effect, but again, it is dose related, and also not everybody is going to develop that much of a problem with the given same dose. So final height score, if you just calculate all these children, those who have gone through this total body radiation, and the greatest loss of height potential in a patient who received both craniospinal and total body irradiation, and the mean loss is about minus 3.0 standard deviation. The final height after leukemia is dependent on CNS prophylaxis, what kind and what dose has been used. and the standard deviation score is 1.4 following 2,400 rats, and 0.6 following 1,800 rats, and 0.5 following no cranial radiation. And younger the age and the female sex negatively correlate with the outcome. So younger age at therapy and the female sex is negatively correlated with outcome. So growth hormone therapy. When you should consider giving growth hormone therapy. Now this area I found the difference between European Cancer Institute versus American. And again, in our country, there is also difference, and it also depends upon how aggressive is the endocrinologist or how aggressive is the hematologist, oncologist. But my feeling is that usually after the age of 1 year, and not only my feeling, the many people said, if the patient has no recurrence, the patient has got no lymphoblast in the bone marrow, and the growth velocity has started declining, that time the growth hormone can be started. However, you must speak to the family, because many parents might feel, this has been my personal experience as well, they might feel that we can live with a short child, but if that brings about or the recurrence of leukemia, we will have problem with that. So I agree with the European. I think 2 years post recurrence may be a good idea, because 60 to 70% of acute lymphoblastic leukemia, if that occurs, and they do occur in first 2 years. So after 2 years, you are a little bit in the good solid ground that you can give growth hormone therapy. Now, respond to the growth hormone in US studies, and so that they will do pretty good. But there are studies shows that it may not, it certainly cannot be compared with the naive or idiopathic growth hormone deficiency. They don't respond as well. However, they will keep the growth velocity within a reasonable range. And growth hormone has shown to increase the leg length, but sitting height is not going to be that much if the patient is treated with spinal irradiation, as I have discussed before. So, as I have said, that there is always a concern about the growth hormone. Is a growth factor, and is it going to be affecting the relapse of leukemia? The several studies and recent studies have shown that it is safe, and it really is not going to bring out the recurrence as people initially afraid of. However, still in European data shows children on growth hormone may have 0.8 to 2% recurrence rate. This is an area of controversy, but my feeling is that most of the endocrinologists feel that if the growth hormone has started appropriately, and the growth velocity has been improved, then it is very safe and the recurrence is not really a problem, it's very negligible. So, I have discussed about the most important problem that we see as an endocrinologist after the treatment of lymphoblastic leukemia or neuroblastoma, uh, whatever may be the cause, depending upon the type of the treatment has been used, the growth hormone and the growth problem is a real one, and that certainly need to be addressed. And so therefore, a close correlation between a endocrine service and the hematologist or service is very important. In many of the institution and even the institution that I worked in, the military hospital, that when a child diagnosis with either non-Hodgkin's lymphoma, then lymphoblastic leukemia, of that, the endocrinologist also get involved from the beginning. So when the patient comes to the hematologist, oncologist, at the same time the endocrinologist should be there to get the baseline height, weight, and when they will be drawing a lot of blood, it may not be a bad idea to get some screening, IGF-1, IGF-BP3, thyroid function test, just to have a baseline. And then when the patient come back, once the remission has occurred, and then the patient should be seen both by hematologist, oncologist, and the endocrinologist in same clinic, and the parent should be kept updated. And if the growth velocity is good at 1 year, after 1 year is good, and the 2 years started falling, that may be the best time to start the growth hormone. This is a very sensitive subject because of the fact that there are people and pediatrician, and they have told the family that where the growth hormone might make the tumor in the brain grow, and so there is always a fear of unknown. But we know that we can resolve the fear probably by talking to the family and giving the data that we have, and giving that how do they respond with the growth hormone, and giving the study that has occurred and shows very little of, if any, recurrence, that will do the family, that will feel the family more satisfied, and this must be involved in making the decision. Thank you, but in my second part, I'll be talking about precocious puberty, thyroid problem, and other things that we see in growth hormone, in endocrine dysfunction in post-childhood cancer therapy.